Hi, and welcome to Healthcare IT Today, where we explore the latest healthcare technology trends and discover valuable insights in health IT. I'm Colin Hung, and I have the chance today, and I'm very excited to be sitting down with Dr. McGilion and Dr. Devereaux with the Population Health Research Institute and McMaster University. Some of you may remember that I spoke with both these gentlemen about a year ago about a study that they were doing related to the impact that remote patient monitoring has on patients. So I'm very excited because their study was recently published in the British Medical Journal in October, and I'm here to talk about the results. Gentlemen, welcome to the program.
Thanks for having us, Colin.
Thank you.
I am super excited about this because, as I mentioned just off air there, you're one of the few studies that I know of that really dove deep into the impact on outcomes that RPM can have. And so I'm very interested to dive into the results here today.
Great.
So before we dive in, though, for those that maybe didn't read or watched our prior interview, can you maybe describe for us the nature of the study and kind of what you were hoping to uncover through it?
Do you want to go first, Mike?
Sure. So, Colin, the study, this was a randomized controlled trial of a virtual care with remote automated monitoring after urgent, emergent, or semi-urgent surgery. And the context was that during waves 1 and 2 of the pandemic, these surgeries that are life-saving needed to continue, while other surgeries were frozen to preserve resources. And so our question was thinking about how can we use virtual care with remote patient monitoring to help prevent people from using acute hospital care after surgical discharge in order to help relieve bed pressures. So for example, thinking about how can we prevent people from being readmitted or having to visit the emergency room? So how can we care for them virtually after surgery? And so we sought to look at this question, among other outcomes, in 8 hospital centers across Canada.
Awesome. And maybe if you can remind the audience again of what was the nature of this remote patient monitoring, because I remember us talking about tablets and the ability to connect with nurses and doctors right away. Can you maybe describe that for us?
Sure. So the intervention was comprised of a couple of components. So first, patients were sent home with a tablet-based computer and equipment so that they could take their vital signs for us. And this equipment was provided by CloudDX. And so patients would take for us their weight in the morning. They would take their blood pressure, their pulse, their blood oxygen saturation reading, as well as their temperature. And they would do it for us 3 times daily in terms of their vital signs, their weight once in the morning. And this allowed then our virtual care team, comprised of nurses and perioperative physicians, to look at patients' vital signs daily. Patients were also able to complete a recovery survey covering questions that are of interest to patients of common issues related to recovery concerns, such as, constipation, any symptoms that we need to be aware of. And so patients would have a scheduled video visit with a nurse daily for the first 2 weeks and every other day for the second 2 weeks of the intervention for a total of a 30-day period. Mm-hmm. And if nurses were in doing their assessments to detect issues that were of concern. So if patients' vital signs were out of bounds, for example, we were concerned about safety that way. Or nurses detected a drug error, for example, where medication was not being used properly. They could escalate to our physicians who were on call 24 hours, 7 days a week in order to intervene.
Thank you for that. That's really helpful. So here's the big question. So what did you find? What were the results of the study?
So we demonstrated many things. The first thing is that we demonstrated huge differences in terms of drug errors being identified and corrected with virtual care. So remarkably, when patients go home after surgery, in the virtual care group, we identified that 30% of patients had drug errors. And of the patients who had drug errors, they had an average of 2 drug errors. We only identified 6% of the patients in the standard care group with normal care were identified of drug errors. That's a 24% absolute difference. And also when it came to correcting the drug errors, it was a 24% absolute advantage the virtual care group correcting those drug errors. We also saw a very striking result on decreasing pain and also moderate to severe pain in patients undergoing or patients randomized to receive virtual care with the remote automated monitoring technologies, and very substantial big effects in this. So 12 to 14% absolute differences favoring the actual virtual care group. The other thing that's interesting about the pain, so we looked at all forms of pain medications, interventions, and we showed that in fact, it was done with the most simplest and safest approach. We saw this huge differential in the use of Tylenol in the virtual care group as opposed to narcotics and other things. So it shows that we can much better control patients' pain even by using very well tolerated, very safe interventions. Perhaps the most important thing though that the trial showed was that when we designed the trial, we had set thresholds for which nurses were supposed to escalate care to a physician. So if the heart rate was at a certain level, either low or high, or the blood pressure was a certain level low or high, or the oxygen saturation was low, temperature was high, the nurse was supposed to escalate care. However, individual physicians or centers could alter those thresholds. And what we saw, I think, offers a really crucial insight into how do we make virtual care with RAM effective. We saw that there was enormous variation across the sites in the frequency with which nurses escalated care to physicians, and the absolute number of escalations per patient, and a huge effect on whether or not this led to changes in management like drug changes. And so the centers that had the high escalation of care had an enormous effect, 45% to 55% relative reductions in acute hospital care. So either coming back to the emergency room or getting readmitted to the hospital, brief acute hospital care, ER visits. So it shows that if done appropriately, you can have an enormous effect. But I think that this is one of the things that has been missed in a lot of the research in this area. I think there's a tendency for all of us to believe that if we put technology in place, it will naturally improve things. And I think that often that will not be the case. You need to have good technology that can identify problems. But if you don't have a clear path to who is going to address those problems and stick with that path, and you don't change management, you will not change outcomes. And so what we saw, where you change management, we saw these really big effects that dramatically improve patients' care post-discharge.
Wow, there's a lot to unpack there, but let me just try to summarize because I want to dive into those three things you talked about. So it sounds like right off the bat, there was an improvement in medication errors in terms of finding them and detecting them in the group that was on the remote patient monitoring technology. We also saw an improvement in terms of pain management, and in terms of the hypothesis of reducing the number of ER returns because readmissions, right? Because of the frequency of interaction with the care team, which was enabled through the technology. And to your point there, the point you're making is that it's not the technology itself; it was the fact that they had a process and the people to back up that, or to help out that patient essentially, so they didn't have to come in.
Exactly. So yeah, so in the centers where people were, using the thresholds as we had, set up ahead of time, and there was a really close working relationship between the nurses and physicians, because they are a dyad that are crucial in this type of technology. So, nurses are the front, line, interacting with the patients very frequently, but it has to be that there is a physician group that is engaged and very willing to jump in with the nurse when there is an issue identified and change care. And if that happens, we saw these huge effects. And so, that I think that it really offers a really crucial insight to all research in this area. We're focused on the perioperative setting, but there's all kinds of research like this that's happening, as an example, in people that have heart failure and et cetera. And I think the more I look back at that research, I think there's been a lot of inconsistencies in those results. And I think it's really being driven by the technology itself won't solve the problem, but it allows you to be in the game. Without it, you're sunk, but you need also a committed team that's going to follow the process of identifying the problems and then being engaged to actually change care. And with that, you can see big effects.
Dr. McGilion and Dr. Devereaux, did your study identify or give you an indication of what the optimal might be in terms of those thresholds? Because you're saying that basically if someone fell out of the threshold, that triggered someone to intervene. And those that essentially had more intervention did better. Did your study indicate like an optimal number or an optimal way to set those?
Do you want to go first, Mike?
Sure. Well, Colin, there are individual parameters that we set for each vital sign
Okay.
based on our perioperative physician, surgeon, and team input to think through what would be most. But I think the key is to understand that we need to stick to the parameters and standardize those, and so that when you alter, process, and relax those, it stands to reason you're not checking on the patient as much. It could be that the vital signs alert the nurse, we investigate. Okay, we understand why it's elevated at the moment, for example. We've already discussed this with the physician, or we need to go back and look. But it is about eliminating opportunity for allowing these things to slip through undetected. That is the key issue. And so in additional research, in one of our next trials, we'll be looking at this question again, but without relaxing those parameters across our sites. And Dr. Devereaux may want to comment on the individual parameters per se.
Yeah, so the only thing I'd say, Colin, is that it's clear that the parameters that we actually set, like for low heart rate, high heart rate, low blood pressure, high blood pressure, low oxygen saturation, temperature, respiratory rate, they work. However, we're getting into 2 more trials just very soon, which will keep exploring what is the optimal threat. We know those work, but it doesn't mean that still, it doesn't mean that can't be modified somewhat, even with different populations. So I think like a lot of things, it will be that for that population, the ones that we identified actually work, still might be able to find some more efficiency, but we're also next moving to patients having elective surgery, and there it actually may be different. And so more work needs to be done, but certainly the parameters we did end up establishing worked really well if that's what was followed.
I want to go back to something that you said earlier, and we'll come back to this topic again, but what was the nature of those medication errors that you mentioned? What was discovered when those patients were on the remote patient monitoring?
Yeah, so it's very interesting. There's several aspects around the drug errors. So errors of omission were the most common. So in other words, patient were supposed to start a new drug, they didn't. Errors of commission, also a problem. They were supposed to stop a drug, continued it. Dosing errors, frequency errors, all kinds of permutations were discovered. It was also interesting that we looked across where did the error happen. About 70% of the time it's with the patient, and that's not shocking. I mean, we're usually dealing with older patients who are coming to hospital on 5 to 10, medications. Some of those medications are being stopped, the dose is being changed, something's being added. And it's not a shock that, when they go home, there's going to be this confusion about what they're supposed to be taking. And I think that unless we put in place a system like this, where there is essentially the day after they go home, a drug reconciliation that's going through what they're supposed to be on, then you're destined to have lots of drug errors. We also found, though, that 20% of the errors actually happen with physicians or nurses in the hospital. So physicians forgetting to write a prescription that the intent was they were stopping drug X, but they didn't put in the prescription to go to the pharmacy to stop drug X, or they were supposed to start a new drug and it was being written in the orders, but not a prescription to give to the patient to start the new drug, and it gets missed. Sometimes there was errors in the information that the nurse conveyed to the patient. And finally, it was the least problematic group, but we also didn't identify errors at the pharmacy level. It was just under 5% of the time the error was at the pharmacy level, and they just didn't fill the prescription as prescribed. But the truth is the pharmacy is a minor issue in the overall problem.
Sure.
It's overwhelmingly with patients, which is understandable. And I think unless you have a system like this in place, this is going to be the reality. But there is still, a reasonable number of the problems are happening with physicians and nurses at the time of discharge, and we also need to have solutions that are going to overcome that too.
So the fact that these patients were having a regular review with the nurse around their post-surgery recovery or post-procedure recovery, it was then that these were discovered, or the patients brought these questions?
Exactly. Yeah.
Okay.
So the problem is that when patients are randomized to standard care, like I think it was 75% of patients saw a physician in the next month after they were discharged.
Right.
That means 25% never even saw any physician and they didn't see any nurse. And when they saw them, it's typically 2, 3, or 4 weeks after the surgery.
Right.
And a lot of times they may not be doing drug reconciliation. And a lot of times it was their family doctor, like they may not even know at the moment what were they supposed to be on
Right.
based on the discharge. They may not have the discharge note yet. And so, I think that there's all these steps where these errors can happen. So like in the standard care group, you're just not going to pick these things up, versus in the intervention group, because we mandated that there will be drug reconciliation at several times, but one key time is the day after people go home, because you want to catch it right away, and you can capture it right away and then correct it before it becomes a problem. And so by mandating that had a huge effect in terms of preventing drug errors.
Wow. That's something near and dear to my heart, because that's something that I worked at a company where we tried to help prevent, and medication errors are one of the leading cause of admissions back into the ED. So it's amazing that just by having the regular check-in and having that conversation with the patients, you were able to uncover so many issues and help correct them, right? In terms of, helping the patient even understand, oh, like I'm supposed to be taking this twice a day, not once a day, or not, every other day instead of twice a day, right? As a common mistake. So that's wonderful that was an outcome. But let's dive into that second point you talked about, the pain, because of course that's a big issue now with opioids and the aversion to using them. And what I hear from what you said is that people were able to manage their pain better through use of the remote patient monitoring technology, and were able to use less, I'll call it less harmful pain medication, like things like Tylenol and over the counter. Can you maybe expand on that a little bit?
Sure, I'm happy to start. Yep. So just in terms of the intervention structure, similar to medication reconciliation, one of the things we've learned is that, this is people in transition after, surgery. So they need help, and we need to understand. And so regular communication is key. So as part of the system, for each scheduled video visit, the nurse would assess pain intensity. And, pain assessment is something you need to do carefully. So you need to think about, how intense is your pain right now, but also assign meaning to the numbers for people so that people understand 0 is no pain, 1 to 3 is mild pain, 4 to 6 is moderate pain, and 7 to 10 is severe. And to be regular in the use of those anchors so patients understand what you're asking. So then we can get accurate information. And so we did that assessment with every scheduled video visit, but we also took a deeper look at pain at a couple of time points where we also looked at, on average, what's the worst pain during the day for you? And is pain different upon rest and upon movement during your recovery? Because we know there can be challenges with assessment accurately if you're not asking patients about their activities of daily living. And so, through this process and, the constant assessment and communication with physicians, we're able to optimize, with simple pharmacologic and some non-pharmacologic recommendations during the daily assessment, how to keep pain at a level that's in the mild range and make a difference there.
Interesting. So again, similar to the medication reconciliation, through the regular contact, through the interactions that the patients were having with their care team, physicians and with nurses, they were able to essentially keep the pain levels from getting too high because they were able to see and report on the levels of pain through all the interactions. Did I get that right?
To work as a team together to optimize pain control with the available strategies, but also to do it carefully, as Dr. Devereaux had mentioned.
Also, the other thing too is that when patients go home, a lot of people are fearful because of everything that's happened with narcotics. And a lot of people think I should just live with pain. And ideally, we don't want people to have to live with suffering if we can prevent it. We're not saying there has to be zero pain, but we want to make it so that it's definitely manageable. And what a lot of people don't realize is that there's actually very well tolerated low risk interventions like Tylenol that we can use. But the problem is if a healthcare provider is not talking to the patient to know that they're having substantial pain and the patient's just trying to ride it out because they think that this is the right thing that they're supposed to do, we have some patients who are suffering unnecessarily. Moreover, there is a strong relationship that people who develop post-operative pain are at risk of getting chronic pain. And we don't know that it's truly causal, but there's a very strong relationship. And, number one, we just don't want people to suffer unnecessarily. And secondly, it may have long-term consequences. So again, just by not having the interaction, to recognize, yeah, the patient's having substantial pain here, and we have things that we can do that are really low risk and can help them get through this, that opportunity is just missed. And that's, what this research so clearly demonstrates in a very big way.
Amazing. I mean, these are 3 phenomenal results. I mean, again, intuitively, I think people were hoping that this is what would happen if you use remote patient monitoring, if you check in with your patients after a procedure. Intuitively, this is what we all think this technology and this kind of process can do. It's nice to have it proven through the study that you have done. So let's switch for a moment to the insights. So what recommendations or what things can be done now if I'm an institution that's kind of implemented remote patient monitoring or thinking about implementing remote patient monitoring? What kind of insights or recommendations do you have now that you've gone through and done this study?
Well, I think an absolutely crucial thing is that you want good technology that is valid, reliable, that can be used to identify when there is a potential problem. You have to then have a clear pathway of how that care and that problem is going to be addressed. And if you just assume that it'll magically happen, it'll take care of itself, I just think it's unlikely to happen. That's what we observed. And so that to me, that is the most crucial message out of this, is that technology is super important, because without it we won't even be in the game. Mm-hmm. But if you do not have a clear pathway of how you're going to address the problems, and you don't make sure that you have an engaged team that wants to say, hey, I'm going to be available, I'm going to do this, you're just not going to solve the problem.
So in terms of practical rollout, to add to what Dr. Devereaux has said, a couple of other lessons for us too is, success means a few things in terms of the setup. And so for patients and family, you've got to have a good system for training people. People may be apprehensive about using the technology, but if you have a regular system that's clear, people really quickly adapt to using this well. Older people can come around to it very quickly and get comfortable, but you've got to have that comfort in your clinical team who can help patients problem solve as well. The other thing is, we try and look at things like how to simplify the setup for people. So using a cellular enabled system with a data plan that doesn't require necessarily that patients have an infrastructure at home, like Wi-Fi. Some do it, but for us, it was important to keep things like that simple, so that the burden on the patient side is minimum. And as technology evolves, that's going to become easier over time. Another thing that we really looked carefully at was to ensure that our team, for future studies, what we've learned is that co-location is ideal if you can set it up. And so that nurses in a common location where they're accessing patients remotely, but it builds a culture of excellence so that you can become comfortable in the practice of virtual care and conferring with their physician colleagues, so that people are able to discuss cases and build confidence with delivering care in this way. So those are some helpful strategies in terms of the practical rollout of things.
Yeah, I want to emphasize the point that Mike just said, which I really think comes down to teamwork. It is absolutely crucial. And I think another place where people are vulnerable to make errors with this is that they just assume you can do this in the corner of your desk, and you don't, like this is something that can just be done on the side. you really want people that are focused on it and people that are going to be intensely involved with it, because it's like anything in any area, which is true of healthcare. If you put smart people onto a problem and they're intensely working on it, invariably they'll start to come up with stuff that starts to work. If everyone's just off on their own doing this on the side of their desk and it's not being focused, I just think, again, the likelihood that you will get to the right solutions and the right team mixture that allows you to have the efficacious outcomes is low. So this co-locating of the nurses together, team system, charge nurses, oversight, lots of learning, lots of discussion, actively engaged physician group, I just think is absolutely crucial if you really want this to work.
Again, lots of really fantastic points here. I love the point you just made, Dr. McGilion, around the fact that people have to consider how to train and get the patients comfortable with whatever technology you're rolling out. I mean, they're bound to have questions. They're bound to not know how to use it. So you have to be prepared to have the supports in place to teach them, right? And it sounds like that can be a nurse, but it could be other people from the hospital as well who can teach and walk the patients through this. And it sounds like they adapt very quickly. It's not like this constant burden of, well, how do I do that again? It sounds like they get it pretty quickly, which is very encouraging, because I think that is one of the myths maybe, or worries, that people are like, oh man, I'm going to be in the tech support game with these elderly patients, just teaching them how to use this cuff every day. Sounds like that was not quite the experience. You taught them, they learned it, they adapted it, and they were able to make it part of their day.
For sure. And, and it's putting ourselves in the shoes of the patient and family at home. So thinking about, what would this be like for me? Were I in this situation? And so, it's organizing simplicity that's standardized. And so, for example, we progressed, they brought the equipment home. We consulted with CloudDX extensively how to make that process smooth. And we progressed patient and family from a phone call to onboard them to then connecting with video while we're guiding them over the phone, so they feel comfortable that first time doing it. To just, eliminate any anxiety around the technology, and then solve problems with them in real time. So being responsive is another key. You've got to have a setup where if patients and family have questions, we're on the other end.
One other thing too is that, like, we've worked with a lot of companies using different technologies in this space. A compliment to CloudDX is, I think, and maybe because they're newer and they're more nimble, they've really gotten the message and they've responded in a really positive way of how crucial it is that this is seamless and simple for anyone to use. So like their stuff is Bluetooth enabled. Like I had reservations when we first started down this line of research, would elderly patients get this and know how to do this? The remarkable thing we had is that people didn't want to give back the technology because, like they had this instant access to the system and they had all this feedback and so I think CloudDX has done a great job in working on their technology to make it super patient friendly and simple, and also just as a company being responsive to the feedback of how we can keep doing that. And I say that Mike and I don't own stock in the company. We don't work for the company. We work with many other companies, but in fairness, I do think that they are doing an excellent job, and I hope other people start to follow the path that they're doing in terms of really recognizing how crucial this is.
Was there anything in particular that surprised you going through the study? Was there a result, something during the process that jumped out of you saying, wow, that's kind of unexpected in a positive way? Was there anything like that happened?
The extent I expected drug errors, I did not expect that 30% of people would have an average of 2 drug errors each. That I did not expect. And also too, the other thing that's actually remarkable is that even during like one thing I was worried about the trial, like Mike and I discussed a lot up front, is that our estimates for the sample size calculation were based upon data pre-COVID. So this was how often people came back to emerge or were readmitted to the hospital. But obviously during COVID, people were way more hesitant to come back to the hospital, either to emerge or be admitted. Despite that, 27% of patients in the standard care group came back to emerge or readmitted to the hospital, essentially half and half. Like 27% came to emerge, 13% were readmitted to the hospital. And when you think about that and you think about the number of surgeries we're doing, it's absolutely staggering. And so these kind of interventions end up being crucial because, number one, we just don't want to have people suffer and have these things happen. A lot of times when they come back and they're readmitted, there's a big problem and it takes a long time to treat. But also, we now have this massive backlog of surgical patients waiting for surgery. So every time someone comes back in, it's now blocking a bed to get another patient through the process.
Gotcha.
And, so I think those two things were the things that just jumped off the page to me about just the magnitude of that problem and how, virtual care with remote automated monitoring technology is a real solution to help address that. Still need to make more advances, but there's no doubt this shows some real ways that you can actually start to make an indent on the problem.
Dr. McGilion, what jumped out for you in terms of anything surprising for the study?
I was the same issues. I mean, Dr. Devereaux and I discussed at great length the things we participate with our whole team, and just the extent of what we saw, and in terms of the things that can happen to people in care transition, and the need to smooth those transitions with these kinds of innovations. So it's been validating for us to see the extent of the issues that we are able to address, for sure. And there's room to move forward. So there's things we need to think through around efficiency, for example. What we're doing now, involves the time and consideration with people involved in a focused team. In future, we're hoping to think through things we can automate so that we can preserve more time and more patient throughput using more advanced technologies. So with Cloud DX, we're going to be examining, can we get a more nuanced appreciation of signal of patient deterioration with advanced tech that allows us to observe people's physiology, multiple parameters, and think through algorithms that could warn us even earlier beyond what we can potentially detect on a video visit. And so we're excited about the directions this is moving in.
That was actually going to be my final question to you. Where are you going next? What are some of the things you're going to be looking at, either in this area or others?
Well, one big area is that, like, the research we just did randomized patients at the time of discharge from hospital after they had completed surgery. And importantly, all these kind of interventions, they're going to cost some money. So the cost economics of all this ends up being very important. Now, if we're preventing ER visits and readmissions, that saves money, that can offset some of that cost. We believe there's another place where there's a real potential to save money, which we didn't address in the first trial, and it will be addressed in one of the two trials we're about to start. We want to move randomization back to prior to surgery in elective cases so that the surgeon and patient will be aware that the patient is randomized either to normal follow-up when they leave the hospital or to receive virtual care with remote automated monitoring technology. And we are hopeful that that will facilitate 25 to 35% of the patients going home sooner than would naturally occur with standard care, because the surgeon and the patient will know, if I go now, I have 24 hours a day access by pushing a button to a nurse and a physician, and I can have all my vital signs being monitored at home. And for certain, many people would rather be in their own setting, but they just want to know that they are actually being monitored and they have a backup system of people who know who they are, what's going on with them, and can quickly address their problems. So if that is also true, that we can get people home sooner, that's another important economic part of the equation. And so that's one of the things that's about to be studied in one of the trials that we're about to start.
Interesting. That is another study I'm looking forward to hearing the results from.
And we will look forward to sharing them.
No, but this has been wonderful. I mean, again, like, I'm so impressed that, that a trial like this exists, that we actually now have proof that this type of intervention coupled with this technology works to prevent all sorts of things and has all sorts of benefits, from medication errors to pain management to readmissions. It all seems to be going the way we all thought it would, which is to decrease all of that, right? Which is phenomenal. So I really appreciate both of your time and sitting down with me to kind of go through the study.
Colin, would you allow us to make one plug before we end?
Absolutely, for sure.
The one thing that I would encourage anyone out there, so the issue with doing all this kind of research is that it takes real money. So we wrote a crazy number of grants for that last trial. We're in the process of writing a bunch of grants for this trial. But we always need money to answer these important questions. For certain there's companies that stand to benefit from the monitoring companies, but also even telecom, companies benefit because cellular packages are attached to every one of these patients. Also, there may, from an insurance point of view, but just I'd encourage anyone out there who's listening and says, yeah, this, potentially also has relevance to our industry, please do consider, contacting us, because the only way this stuff gets done is, is with a lot of different funding sources coming together to really answer important questions. And we need all the help we can get to make that happen.
Absolutely. So if anyone out there who's working at a telco or working at these kinds of companies who has an interest in this area, definitely reach out to you. And how can they do that? What's the website they should go to?
The easiest thing is just to contact, myself, PJ Devereaux, or Mike McGilion through McMaster University. We can give you our email addresses. Maybe you could put up our phone numbers to the office is 905-527-4322. And then extension 40654. But if you just search for any of our names online, you'll find our contact very easily.
Awesome.
We are definitely not hiding. We're out there.
No, and hopefully this study.
We're sitting by the phone.
Yeah, well, I'm going to say you're going to sit by the phone and wait for it to ring now.
Well, we're going to be out there beating the bushes and getting the studies done. But anytime we get a chance to make a plug for this stuff, it's important, just because just the reality that it takes enormous amounts of different funding to pull off these things.
Well, again, Dr. McGilion and Dr. Devereaux, thank you so much for your time today. Really enjoyed speaking with you and look forward to the next time we get together.
Thanks so much, Colin.
Thanks for having us.
Hey, if you enjoyed this interview as much as I did, we'd love for you to subscribe, rate, and give a review on iTunes, YouTube, or wherever you're listening or watching this. Also, head over to healthcareittoday.com to access free resources, industry news, and insightful articles. You can also connect with us on Twitter using the hashtag HITSM. I'm Colin Hung. Thanks for being here.